infections, which constitutes a priority for the medical authorities in our country. And to illustrate this, I will present official data reported at the level of the Ministry of Health, the situation of influenza cases of the level of National Institute of Infectious Diseases, Matei Balș, and the cases of influenza in children between 0 and 14 years. For the diagnosis of influenza infections, we used MyPOC rapid test, and I will present the results of this test and a comparative analysis between 2013 and 2014. To exemplify the neurological complication of influenza, I will present 2 cases, Guillain-Barré syndrome and encephalitis, and finally a few conclusions about what have we learned from this disease. As I said, supervising influenza infection constitutes a priority for authorities' health in our country. The National Center for Surveillance and Control of Communicable Diseases with the National Institute of Public Health in Bucharest coordinates the influenza surveilling system. Data is collected by sentinel physicians, and that results in a weekly report during the influenza season. The season 2014-2015 started in the first weeks of this year and reached the peak in the weeks 7 to 9. The last positive detection tested were recorded in week 18. This year, influenza activity was higher compared to the last 2 seasons, and this season were characterized by co-circulation of influenza AH3 and 2, AH1 and 1, pandemic of 9, and influenza B viruses. Institute Cantacuzino confirmed 1,103 cases of influenza. 507 cases were influenza A, out of which 2,083 cases were subtype H3, 180 subtype H1 and 1, and 44 unclassified. 592 cases were influenza B, and there were also detected 3 co-infections, AH3 and B, and 1 co-infection, H1 and B. Last season, there were recorded 33 deaths, from which 24 were determined by H1, and 9 cases were determined by H3. Whereas this season, there were recorded 40 deaths, from which 25 were determined by H1 and 1. 9 cases were determined at influenza B, and 6 cases were determined by H3. In our institute, there were counted 2,139 cases this season. The most important number of cases was counted in March, and in April we had significant decreases of the number of cases until the end of this month. This slide focuses on the number of cases according to age group. We can see there were recorded 360 cases in children between 0 and 14 years. That represent 17% of the cases. The rest of 83% is made up of patients above 14 years of age. For the diagnosis of respiratory infection, we use MyPOC rapid test. This is an innovative multi-analyte point-of-care testing of respiratory tract infections. It's a fully automated immunoassay test system which detects antigen for influenza A and B, 5 other frequent viruses, and optionally Streptococcus pneumoniae antigen. This method uses fluorophore-labeled antibodies, and the detection of the fluorescent signal is carried out by a laser with optical separation of unbound and bound tracer fractions. The preliminary results are provided in 20 minutes and final results in 2 hours. It's an easy-to-use method. As you can see, the swab is cut into the tube. We use Copan swabs. We add buffer and vortex, and bar-coated sample tube is inserted into the analyzer. As I said, the preliminary results is provided in 20 minutes, and final results, which look like this, in 2 hours. And these are the results of MyPOC test in our institute, which in these slides we present the distribution of typhoid influenza viruses in children. And these slides confirmed that influenza B was predominant in the season that just came to an end. This test, MARIPOC, enabled us also to establish the etiology of respiratory viral infections in the last 2 seasons. So last year, we see in this slide, 55% of all the cases are caused by influenza A, and 27% of cases were with RSV. 8.9% of the cases were co-infections, and last year we had just a few cases of influenza B. And whereas this season, 44% of cases were determined by influenza B, 28% of season influenza A, and 13% of all the cases were with RSV. We had only 3% of cases of co-infections. Most of these cases were confirmed by PCR, and with these slides, we want to demonstrate that PCR also let us demonstrate that after 7 days of treatment, most of the patients still had the virus. And in these slides, we show that the dynamics of the way in which the virus came from positive to negative. And we recommend for this. For that, we recommend to prolong the treatment up to 10 days. And as announced, I will present 2 cases of complication of influenza in children. This is the case of a 3-year-old boy. The onset of his disease was with fever, rhinorrhea, and cough. And after a few days, he accused headache, photophobia, pain in lower limbs, and gait disturbance. He was admitted in the territorial hospital, and their first diagnosis was encephalitis. He was treated with dexamethasone, mannitol, and ceftriaxone. The fever decreased, but in a few days, the evolution was unfavorable, and neurological serial exams revealed the abolished tendon reflexes. The fever grows up again, and he was transferred in our clinic. At the admittance, he had fever, cough, dyspnea, dysphonia, weakness in the lower limbs, and gait unsteadiness. Laboratory findings demonstrated that a MARIPOC test was positive for influenza A. RT-PCR was confirmed influenza AH3. We also performed lumbar puncture, and in CSF there was demonstrated dissociation albuminocytological with a lot of proteins and no cells. It was also performed electromyography, which revealed demyelinating neuropathy with secondary axonal suffering. Our diagnosis was Guillain-Barré syndrome, and he received a treatment with IGIV, oseltamivir, dexamethasone, with a short course with decreasing doses. The outcome was favorable. The motor function was in remission, and he needed a short period of time to recuperate his motor function in a specialized facility. And the second case is about a boy, an 8-year-old boy. His diseases started with fever and seizure with generalized hypotonia. After post-crisis, he was sleepiness with confusion and right hemiparesis. He was directed in our clinic, and the neurologic exam showed the altered mental status because he was confused, perplexed, aphasic with right hemiparesis and right central facial paresis. Upon conducting laboratory findings, we discovered on MARIPOC influenza A positive. RT-PCR confirmed also influenza H3 virus. CSF was normal, even PCR for viruses was negative in CSF. We performed also EEG, which shows slow waves, asymmetric, predominant on the left side. IRM was normal. Our diagnosis was encephalitis, and he received a treatment with oseltamivir, dexamethasone, mannitol, and IGIV. His evolution was favorable, but upon discharge, he still presents slight right central facial paresis and discrete pronation on upper right limb. A few conclusions. MARIPOC represents for us an important tool in the diagnosis of respiratory infections. Neurologic impairment is one of the main complications of influenza infections, and due to the prolonged persistence of virus in the airways, we recommend to extend the antiviral treatment for up to 10 days. Thank you.
Any questions?
Thank you, that was excellent. Two questions. One, what is the vaccine availability in your country? It seems like you have a lot of disease, and especially in March you have a lot of B, which is typical.
In our country, we use the Vaxigrim of Sanofi Pasteur vaccine. We have a national program for vaccination. There were used 500,000 doses, and it was the medical staff was vaccinated, and also the elderly, patients with chronic diseases, and children from institutions.
So about how many of your pediatric population was immunized?
I don't know exactly the percent.
My other question is, it seems like there's delay in testing for influenza in terms of initiating treatment. Can you explain that, or is it just a cost kind of thing? Because in our season, and it probably depends on different countries, we start testing from October to March, and immediately we'll start also oseltamivir.
We started this test from last year. It started from October because we get these devices in last year in October, the end of October. We started testing, but the first results were at the end of December, and the most important number of cases was like this in spring. And this year also we demonstrate the first cases of influenza were in January, and the peak was in March.
So at least in adults, Guillain-Barré syndrome will usually develop sort of days or weeks after an infection, classically Campylobacter. Can you explain why the 3-year-old child in your first case developed Guillain-Barré syndrome more or less straight away with the infection? What's going on there? Is it a different mechanism?
It wasn't in Bucharest. It was far away from Bucharest. It was in a territorial hospital, and they didn't get a test to diagnose influenza. And when he reached our hospital, we tested him from the beginning, and we found out the influenza test positive.
So it was, in fact, many days afterwards that he developed.
There were many days for the onset of these diseases. There were.
Okay, any other questions? I've actually got one myself. I noticed that the incidence of flu was biased much more to the H1 than the H3, which is actually contradictory to what generally happens. It's usually H3 that's the more predominant strain of flu, even allowing for the difference with pandemic flu. Do you think there's a particular reason for that, or do you just think it's one of those quirks?
I don't know.
It's a quirk, yeah, okay. I think that's fine. I think that's probably what it was as well. But I was curious because I've been trying to answer the same question myself at the moment. So it's like I just wondered if you had something that would help.
Thank you.
Thank you very much. That was.